You may have recognized that I'm the only German participant at this conference, and there are many reasons for this, because on the one hand, we don't have a debate about hospital at home in Germany yet, and on the other hand, we have a very traditional hospital-based and hospital-focused and physician-driven, highly invasive healthcare system, which is not integrated when it comes to collaboration between hospitals and outpatient services, general physicians, or nursing care services. But since the implementation of the German DRG system in the year 2000, we see more and more patients and treatment forms transferred to the patients' homes, especially technology-dependent patients. And we see, on the other hand, a very dynamic expansion of specialized intensive home care services, most of them for profit, and residential concepts for the severely ill. If it comes to home care of these patients, we have two different funding systems, which is important to know. One is the long-term care insurance system, mostly focusing on the elderly and the people with long-term care need. They get personal care and housekeeping assistance by the social care insurance. And on the other hand, we have the statutory health care insurance, which is funding the support of physicians' treatment and the avoidance of hospitalization. This is based on individual medical prescription and on delegation to nurses. We see an increase in both fields of this care, but especially if it comes to skilled home nursing care for the severely ill, the chronically ill, and the technology-dependent patients. If we talk about this form of intensive home care or care for the severely ill and technology-dependent patients, we at first have to ask, what do we know about the users? And unfortunately, we do not know a lot. We have no available database about these patients and only sufficient information from the healthcare providers or from the healthcare insurances. We don't know anything about the population of its patients and their healthcare needs. It is estimated that we have more than 20,000 invasive ventilated patients in private homes, but we don't have the exact numbers for these patients. And these are patients of every age, from the newborn to the elderly, suffering from a lot of different diseases in a lot of different stages of their diseases. Most of them are critically, chronically ill or in a dying phase, often after traumatic injuries coming from the emergency unit over the hospital to the home care arena. All of them have to be dependent on life-sustaining technology, and following German law, it is important that they are supervised by a qualified nurse 24 hours 7 in their private home. So in every home we have a nurse there 24 hours, and the medical services are coming from the GPs or from the residential specialists like pulmonologists, for example. What are the challenges we see in this field of home care we have in our country? In most cases, the nurses work very isolated, and they only have infrequent direct physician contact based on the personal relationship to the physicians. So there are no regular meetings or something like this. That's the same with all the physiotherapists, the speech therapists, the occupational therapists, or the pharmacists involved in this form of care, because in Germany, all these service providers in the outpatient arena are single businesses run by different organizations. Sometimes family members are involved in this sort of care, but sometimes there are no family members. And it is difficult for the nurses to have oversight of all these people involved in the care. We have a lot of home care technology in this setting. Sometimes the apartments look like an intensive care unit. We have not only the technology for the therapy, but also for the surrounding, for the control of the surrounding and things like this. The housing conditions are very, very heterogeneous. We see single apartments, one-room apartments. We also see houses where the nurses live together with these patients. The environmental is hardly to control from the nurses, and we don't have a safety management system for this. If it comes to patient safety, very important topic, we have no reliable or standardized information yet about what is going on behind closed doors with the patients. We did a lot of studies during the last 10 years about these topics. Most of them were in the field of healthcare epidemiology, so we tried to find out who are the service providers, what do we know about the patients and things like this. And some were qualitative to explore the patient views, relative views, and the views of the service providers. And if we ask these people, you have to remember that we don't have direct access to all these different organizations. They do not belong to Charité, for example, or to other hospitals. So as a researcher, we have to ask to enter these private homes. What we see is that one of the biggest problems is the overlooking or misunderstanding of nonverbal communication offers to patients. But we also see a neglect of patient or technology-related monitoring tasks. Therefore, you have to know that the nurses are in the private homes for 8 to 12-hour shifts. That might be sometimes very boring, and so they are not very concentrated on what is going on while they are in the private homes of the patients. It's an underestimating of collaboration and coordination requirements. They are not planned if the nurses and the doctors have to meet. It might happen, but it's not regularly the case. And we see an under-evaluating of the need for negotiation of the services, for education of, for example, the service providers and the relatives in the private homes, and for supervision of all of these. Interesting is that the people we ask about what are their experiences with this sort of care, they say that a lack of competence, self-confidence, and professionality of nurses is one of the main problems. And therefore, you have to know that in Germany, nurses working in this area are still traditionally educated only on a vocational training level. And that because of our nursing shortage, we see a lot of nurse migrants, for example, from Eastern European countries who are not able to speak German fluently or to come in contact with the patients. What are the safety dimensions from the user perspectives? As I mentioned before, it's very hard for us to get an insight into what is going on in this field. As a researcher, we heard from the patients and the relatives about a lot of risk situations, many near misses, and incidents in intensive home care, and you have to be aware that we only have information about the patients and the relatives and the nursing care services who opened the door for us. So we don't know the worst cases, probably. We see a lot of risky situations which emerge due to structural and management problems, how the services are organized and how the people collaborate or integrate their services. And we see that the patient and the relatives have very high expectations about what is going on in their private homes with the nurses, especially the nurses. They feel safe when the relationship with the nurses is working very well, when they are able to bond with the nurses and to work with them on a trust basis. But if there is a mistake, for example, then the trust is vanishing and the patients and the relatives feel very insecure. Interesting for us, because many of these studies have been funded by the German government because of the technology aspect. It was the idea that technology in home care should be fostered. And what we saw is that technology, home care technology, is not very important for the patients or the relatives. For them, it is important that there is someone who is able to work with this kind of technology. What are the next steps we have to do now in our country? We have to examine and reconfigure the environments of policy, payment, and regulation. The German government already started with that. In the last year, there has a new part implemented into German law that the medical services of the healthcare insurances are allowed to control what is going on behind these closed doors. And in a few weeks, we will have a meeting with the German government and all the important organizations in our country talking about the idea of intensive home care and what kind of role it should play in our healthcare systems. We have to learn more about the experience of patients and relatives, even the very heterogeneous patients and relatives, starting with parents with a little child up to elderlies living totally alone. And we have to establish models of team-based care. We have to put nurses, physicians, OTs, PTs, and all the others together in teams. And we have a model for that in Germany because a few years ago we implemented palliative care as a special funding aspect in our healthcare insurance. And it's mandatory that this palliative care services are provided in a team-based manner from teams with different professions. We have to develop a culture, and we have to talk about this, a culture of safety, and we have to talk about the safety aspects of this sort of home care, this sort of hospital at home, you might say. And especially, we have to talk about the role of nurses in our healthcare system. We have to educate them much better. We have to integrate graduated nurses in this field who have a defined scope of practice and who are able to manage these situations in the private homes. To come to an end, in Germany too, we see advanced care moving from hospitals to patients' home, and I'm not sure if we already have hospital at home in our country, but this sort of care becomes more and more important, and the home becomes a more and more important health setting, not only for the elderly. We only have limited data, so we need research. For sure, we need more information from the healthcare insurances, from the providers about what is going on in this field. We need more access as researchers to these sort of home care because the providers are not doing research in this field, so we should be allowed to enter all the private homes or the shared flats, for example, where technology-dependent patients are living and are cared for. We have a discussion about quality aspects of the different sorts of care, and we have a discussion about safety dimensions, but in our system, safety dimensions in home care are not yet considered. And we have to foster the debate about patient-centered concept for advanced forms of home care, where we really know what is going on and how we can serve these patients in the way that they can feel safe, whatever is going on in their private homes. Thank you very much.